So, first of all, let me say it's a personal delight to be back in Tallinn. About over 30 years ago, I spent quite a lot of time here and also in Tartu as part of a partnership. And sadly, life has gone by, but I'm really happy to be back. And there are three other reasons why I'm happy to be back. One was that I was sitting next to the Minister of Health, the Estonian Minister of Health, about 2 years ago in Helsinki. And we were discussing data and the challenge of data. And he produced his iPad. And in this restaurant, he showed me every last detail of his medical record. This is in Helsinki. And I thought, wow, that's impressive. And so I would like to, as our friends from America have done, I think Estonia has done an extraordinary job, if not certainly one of the world's best, if not the world's best, in assembling a lot of medical data. The second reason I'm really happy to be here is because Maria-Liisa, where is she? Is she still here? Anyway, she was here. Yes, so she is. So about 5 years ago, I took a 30% professorship in Helsinki with the idea of working in Finland to see if we could move the concept and practice of personalized medicine forward. And Liisa Maria showed you this morning how far Finland has come in this context. We're not there yet, but we're a long way along the road. And then the third reason why I'm really happy to be here is because about a few months ago, I was asked to chair the Access Committee of Genomics England, which is the committee, it's the independent external committee that takes a perspective on whether or not particular groups are allowed access, in other words, are allowed to participate in all of the lovely data that Tom and his friends are generating. Anyway, so it's three and a half really good reasons to be here. Now, what I was asked to do, and actually, I think it's a good question, as Liisa Maria said, is how can we generate economic value from personalized medicine and big medical data analysis? And as Liisa Maria said, the reason why this is important is because if we can't, patient pressure alone will make it really slow. So it's really important to show how we are giving better healthcare for the same money, etc., as well as showing how we're giving better outcomes. So that's the kind of things I want to talk about today. Now, this is all very personal, just a personal perspective. So medicine has always been personalized, or at least clinicians aspire to do the right thing for each patient. And in the last 100 years, we've made really dramatic progress in bringing a whole series of new technologies. If you start 100 years back, well, you can think through it for yourself. Different technologies, and now we get to informatics and sequencing and all the rest of it. Molecular biology. And all of that's given us big clinical insight. We've also realized that random decisions by individual disconnected clinicians sometimes are very good for patients, but they can also be very bad. I don't know if you know, but Bach, Johann Sebastian Bach, for instance, was treated by an English clinician for glaucoma, and this treatment consists after surgery of putting fresh pigeon's blood in his eye and then sealing his eye for 3 months, by which time, of course, he traveled on somewhere else. And Bach actually died from the second operation. So, that's an inspired, innovative clinical principle, not more than about 300 years ago, that actually killed one of the greater contributions to our current culture. So that's not good either. So then we moved to blinded, randomized clinical studies. And that was a huge step forward, which then allowed clinicians to communicate. And many of these were sponsored by pharmaceutical companies who wished to demonstrate that their new therapies were effective. And all that's very good. However, where we've got to today, with the technology advancing even further, these guidelines, as they are so rigid and carved in stone, or at least for a year or two, and are quite difficult to move and requiring quite large amounts of data to shift, actually starting to get in the way. And so tomorrow, I think we're now generalized, which means we treat patients as numbers, as statistics, And now the next move forward is to go back to treating patients in a much more personalized manner. And that does indeed mean, that the results of the extensive diagnosis, and here I do not particularly mean genomics, I mean everything you could possibly imagine, necessarily will most likely be done by computer, and the computer will make the recommendations to the clinician and the patient. So when we're talking about economic value to health, I'm much more interested in patients. I'm not particularly interested in economics, except that it is the way in which we, in almost all societies, have chosen to prioritize. It's what drives our thinking. And just so we know what we're talking about, the same thing. So when I say economic, what I mean is more effective healthcare provision at the same cost. In other words, patients do better. Same healthcare for lower cost, which seems to be, in some parts of the world, necessary. And innovative products and services to allow others to do 1 and 2. In other words, if you can do it here in Estonia, if you can show how to minimize mammograms for breast cancer patients, for instance, which is a topical subject, and you have a system that allows you to do it with the different bits of diagnosis, genomics, blood assays, as part of that, you have a system that you can sell as a system. You can export it to other parts of the world, much like, certainly in America, hospitals buy information systems, patient information systems. That's also something I'm sure you've thought about. So services and products can be diagnostics, can be anything. Fourthly, more research funding from international sources. So if you've got a really good base, scientific, technological base, you can get more money, for instance, from Brussels or Washington. And finally, if you've got real-world data for clinical trial and registration studies, people will come here to run clinical studies because you will have the background information. Now, a few years ago, this sounded fantastic and not reasonable. I have to say that I personally have been involved in discussions with regulators both sides of the Atlantic about studies where the control arm is observational data. Now, the first one of those was a very rare cancer. The second one is a rather common cancer. And so the regulators, to some extent, are at least up to speed with thinking about how we might run clinical trials differently. I'll come back to that. Anyway, this is all going to be very difficult. And I'm not even talking about the practicalities of linking up data and all the rest of it. There is a huge inertia, justifiably, but at this particular moment in time, in the context of personalized healthcare, it is very significant. I just offer you the trials and tribulations that Paracelsus had. So Paracelsus is quite well known, as some people call him the father of modern medicine, but actually that might have been Galen in Greece and wherever. But they both had the same problem. The problem was that they wished to bring science and reason to medicine. That was their challenge. That's what they tried to bring. For bringing science, modern science in those days, and to medicine, Paracelsus, this relates to Basel, because I've spent some time in Basel, as you know, was thrown out when he was a student for necromancy, which means dissection, basically, or working out how the body worked. He then went off to the Middle East and developed a whole series of very effective antibiotic treatments, because he was treating soldiers with cuts from the war. Then he came back again, and Erasmus insisted that he should be appointed professor of medicine. And then, yet again, the medical community threw him out because their authority was being undermined, and he was forced to leave Basel once again. The point I'm trying to make is this is not easy, and what we need is to get a coalition of patients, clinicians, and others in order to drive this forward, and we need to challenge the orthodox thinking in medicine in a much more passionate way. But I'm saying it's not going to be easy. Now, my personal interest in personalized medicine sort of grew about 20 years ago when I was being asked, this is when I'd left academia, actually left Finland, and gone to work for Glaxo. And I was asked endlessly, why is it you guys in research can't create effective medicines? And then I was asked and then I was sort of in between the clinical world and the research world. And then the research world was asking, well, why is it you guys, the clinicians, can't find the patients that respond to our wonderful medicines? And this is a dialogue that you may have heard, and it's still ongoing, unfortunately. Slightly better because we tend to put them together in groups, so they have to talk to each other, but it's still ongoing. And when you think about that, it became very clear, actually, that we were never going to be able to create seriously effective medicines for, well, of course we can do it for orphan diseases, where we do, because that's a defined, very small defined subgroup. We're never going to be able to do it for larger diseases like inflammation, Alzheimer's, diabetes, because we don't know who to give them to. Cancers, we don't know who to give them to. And until we understand the molecular pathology behind each patient's condition, and we're able to identify therapies, which may not be drugs, radiation, anything you like, we are not going to make a great deal of progress in medicine in terms of helping the patient. And that is the reason why, as Lisa Maria said, why personalized medicine, it's not a pilot. It is essential. It is essential for progress in medicine. Of course, we can do something with time and motion guys. The kind of guys you see in hospitals, with a stopwatch and an iPad, and they write down, or maybe they've got an iPad these days, they write down how long does the patient stay there, what happens over there, could we redesign the hospital such that the patient only had 100 meters to walk instead of 3 kilometers? Of course we can do all that. But that, and of course we can save money, but that is not going to advance medicine. What's going to advance medicine is personalizing it. And here's just an example. So it's a puzzling thought that actually patients in general, patients receiving a cancer medicine, have a 1 in 3 chance of deriving any benefit from that cancer medicine, which means 2 out of the 3 cancer patients receiving the medicine derive no benefit, get the side effects, and actually there's increasing evidence that if they get the wrong medicine, they die quicker. And it won't be too long before the regulators take an interest in the way in which, the rather random or the rather careless way in which we give out the historical cancer medicines. A little bit more about this. And so, as you know, and I was involved in this, one of the most dramatic examples of this was the BRAF mutation for melanoma, and you know very well what happened, and that is that it's a stunning medicine, and after 15 weeks you see amazing regression, and then after 23 weeks in most patients you see resistance, a re-emergence of the same tumors in the same place. And we think we know how to fix this, and it probably has to do with getting the immune system engaged and all the rest of it. But what it tells you 2 things. One is it tells you that if you identify responding patients, you can see dramatic responses. And the second thing is, if you want to advance medicine further, you better know in combination with which other drug you should give every medicine, because single medicines, particularly in cancer, are extremely unlikely to do much good. Sorry, when am I supposed to stop, by the way, so I do stop? Where is he there? Half part? No, when is it? Tell me. Do, please, otherwise we won't have any questions. 40, okay, 10 more minutes, good, thank you. So, this is for me this is a social scandal. It's a commercial scandal, it's a social scandal, it's a government scandal, it's a payer scandal, and it's a patient scandal. Why do I say it's a scandal? These are new-ish cancer medicines. But the red is the non-responder. And some of these, the highly targeted one, Revlimid and Gleevec, that's quite good, but everything else is less, Velcade, just about, and Lepelin. Everything else is less than half. Now, what that tells me, it tells me what I was just saying, that is that many cancer patients, this is not counting all the old ones, the Taxoteres and all the rest of it, what that tells me is many cancer patients get medicines, really dangerous, powerful medicines, often make their hair fall out, gives them all sorts of other problems, depression, you name it, wipes out their immune system. And there is a very small chance that they would respond. The second thing it tells me is that we in society have not put enough effort with our new technologies into understanding which patients respond. And that is a failing, I just make the point, that is a failing in two areas. It's a failing of industry to invest, but more importantly, it's a failure of regulators and payers to demand efficacious drugs. It's extraordinary. I mean, you've heard people say, if this was a car, you wouldn't buy it. But we do. And it's not the best we can do. It's not the best we can do. My biggest regret from my time in Genentech and Roche is that I was unable to persuade the organization to invest seriously in understanding which patients responded to Avastin, which is a huge, in my view, mistake. For a number of things. It turns out, by the way, for those who are interested, that Avastin actually functions through immune suppression. Oh, sorry, in removing immune suppression. It's an immune oncology drug. It's not a vascular drug, you know. But we never got there. But anyway, so what I would suggest is that regulators, payers, demand that companies invest more in finding out which patients respond, and that's where Estonia could play a really big role. Now, one of the things I would say is that the traditional way of running double-blinded studies. This is a personal perspective from being responsible and involved in running very many cancer studies and other studies. My personal view is that it's becoming impossible to ask the numbers of questions you'd like to ask about combinations of cancer drugs with the information we have about response using the classical clinical trial design. And in my view, the only way we will be able to answer these questions is with ongoing observational data. You can partially blind it, you can certainly make it prospective. There are a number of things you can do, but a completely different approach to thinking about how we demonstrate clinical efficacy is absolutely required going forward in the context of the new technologies and indeed the new medicines. It also requires completely new statistical approaches. I've been to a couple of meetings of statisticians where it is completely clear that much of the statistics that we use currently for analyzing clinical data, actually, particularly when it's multivariant and multifactorial analysis, is actually inappropriate and indeed wrong. And there's a whole new school of how to think about this, how to think about the statistics of big data. And if we aren't already coupled, we need to get very closely coupled to people who think straight and do not take people who are used to analyzing double-blinded clinical trials. They will not be able to help you in this new world. So how can genetics, this is just an idea of how can genetics help us to, what we need is if I start at the beginning, what we need to be able to demonstrate, if we say cost effectiveness, we need to be able to demonstrate somehow that if we use this way of deciding how to treat patients with this cascade, the patients do better and we spend less money than if we use this traditional set. And I understand there's an interesting discussion now about breast cancer, and I think that's a pretty good place to start. And this is the kind of thing you might think about. So let's start with genetic risk. Instead of saying all women need a mammogram or whatever, which we've now decided, Maria told me, America has now decided they're not going to do that, which I think is very wise, and there's been an ongoing discussion. So let's not do that. But some people do need a mammogram. Who are they? How do we find them? How do we focus that? And can we show that by not giving mammograms to everybody, but only giving them to, let's say, 10% of the population, we've saved a lot of money and a lot of things. It's kind of obvious. So this is just an example. So if in Estonia we could show DNA tests for genetic risk, environmental risk, for cancer. So, sorry, when I say environmental, I also mean behavioral and BMI and any other kind of risk you measure. Blood tests, circulating tumor DNA, exosomes. There are all sorts of exciting ways of detecting cancer early. Then we get to physical tests, and then we get to biopsy. When we get to a biopsy, it is, for me, hands up those who've heard of Immunoscore. That's good. Okay. Who is your Estonian partner in Immunoscore? Well, you should have one. Anyway, maybe you've got one. Immunoscore is just another way of defining prognosis. Prognosis for cancer. And the data to date says that it is very much better than your best pathologist looking down a microscope and saying, I think it's a 2A. I'm not going to go into it, but anyway, it's a much better score. Biopsy. Full panel test on tumor sample, I'll come back to that a bit, which is every possible marker that relates to any possible cancer drug or any other drug that you can think of. And then following all of this, the best treatment with available technologies and agents. So you could put together all of this, part of this, with the clear outcomes. You want better outcomes for patients, and you want cost effectiveness. And this is the kind of thing we need to do. And we will get investment into these kinds of studies. We will not get investment, I believe, by saying, I've got a huge biobank, I've got lots of medical data. We've got some investment, but we won't get the real investment. If you just say, okay, well, I'm a great place to come and play. I think we need to be much more precise about what it is that we are offering, and that precision needs to come from experience in our own systems. When you've done that, A, we save money here, and B, we have a system that we can, parts of which, or all of which, we can export. I just wanted to show you a quick example. About 6 or 7 years ago, I became associated with a company called Caris Life Sciences, which is in Phoenix and Dallas, and it's based on the work that Dan Hoff did, but it's gone a long way further. The reason why I'm interested in this, and I continue to go, I keep deciding not to bother, but then I go, and then they've done something even more amazing. So I still go a couple of times a year. What they did originally is they put together all of the assays that would detect the response to any cancer drug. They did literature search, all of the assays. It's about 56 plus, not counting genes. From data. They then started to run an ongoing observational study. Sorry, I didn't explain that. So what the clinician gets back is a computer-generated, but signed off by an oncologist, a pathologist, a computer-generated system, and the drugs in green are drugs that are on formulary and are likely to work according to the biomarker profile. This is not DNA, this is everything, it's all these other things you can see here. The ones in red are unlikely to work according to the literature and profile, thank you. And the ones at the bottom the ones at the bottom, we don't know. Anyway, the point is, this is what it's sequencing. You can see, by the way, for those who are very keen on DNA, sequencing in this assay, the data says it's only about 30% of what you need to measure to get effective prediction of drug response in cancer with today's knowledge. And I think the most interesting thing, so there's a whole lot of new data. The most interesting thing is for late-stage ovarian cancer patients, the median survival of patients treated with drugs predicted to have efficacy was 2.5 years longer than patients who received drugs not predicted to have efficacy. So in other words, this is with 1,000 patients. So this is ongoing. So this is where it is now. And then you come back in 2 years, it'll be different. We come back in 4 years, it'll be different. It's an ongoing study of, I think it's about 30,000 patients. And what's now happening is that there are now big US cancer centers where this is used on every patient, certainly all rare cancers, and every patient. So the amount of data that's being generated in this partnership is really dramatic. But anyway, so computerized prediction of response, ongoing prospective study to find out whether the decision rules we're using are the right ones or the wrong ones. And now this algorithm is driven by the data in the observational study. It's no longer driven by the literature. Anyway, that's the kind of model for the kind of things that ought to happen. And when you show this to clinicians, two things happen. One is they use it for all their patients in the States. And the second thing that happens is the regulators start to get interested, because what this tells you is that some drugs, for some patients, on average, they die much quicker than they would if they didn't get any drug. So funding, research funding, I'm just stopping. Research funding, IMI, there's another 3.5 billion to be got. How much have we got in Estonia? I only ask because IMI was set up around personalized medicine. And so you're in a great place to get it. Horizon 2020, I was on the advisory board of that. That was also set up largely around personalized medicine. And so Estonia, where it is now, has a huge chance to go and get a lot of money from Brussels in partnership. IMI is in partnership with industry, which would be good to allow you to interface, and Horizon is with others. I'm not going to talk about this. This is a wonderful Finnish program that tells you what really detailed clinical information looks like. I'm not going to mention genetic risks except to say that allows you to redefine schizophrenia, as you will read shortly, as looks like more like an autoimmune disease, looks like type 1 diabetes. Not all schizophrenia, but a subset. Anyway, cardiovascular disease, just quickly, if I can. It's the same principle as cancer, so I won't go to the details, just to say that about 4 years ago, we did a very interesting experiment in FIM in Helsinki, where we invited journalists and we tested them for 37 different genetic cardiovascular risk, and then we plotted against the population, and the green ones are the journalists, and then we had a cardiologist on standby, and it was extremely interesting, the fact that the journalists were exposed to this, something that I found very interesting. And that led to the Cardiocompass study that you've probably heard about. This I'm particularly interested in because this is a holistic study, a bit like Lee Hood's, only much bigger, where things like grocery bills are included. So exercise, grocery bills. It's that kind of information. So in summary, personalized healthcare is essential for further progress in medicine. As Lisa Maria said, this is not a pilot. This is where the world is going. The question is, how can we get there quicker and thereby generate value for ourselves and for others? Economic value is generated by running healthcare more effectively. It's the only way possible. Clinical data generation must now move on from classical blinded studies to the new paradigm of ongoing observational studies with big data, because it's the only way you can deal with the complexity of the required decision rules. We need to change the success metrics of healthcare to support, I apologize for the word pilot, but to support tests, tests of decision paradigms, not of drugs or diagnostics, tests of when I decide for these patients like this, and those patients like this, these patients do better, and I save money. Test decision paradigms. As we do this, this will create a market nationally and internationally for systems approaches to provide cost-effective personalized healthcare. And my plea is that please, in everything we do, break at least one orthodoxy, at least one, probably more, not too many, otherwise it doesn't work, but at least one, break at least one orthodoxy. And do bear in mind, it will be challenging. Don't expect it to be easy. But we're going the right way. We're going actually pretty fast, as you can see. And it would be I think Estonia has a very important role to play because you've taken a huge leap past everybody else with your data systems. Thank you.
Thank you very much, Professor, for this disruptive approach. I hope we will take the lead in this area. We don't have too much time anymore for questions, but maybe Jaanus Pikani could just comment from Estonian side. Do you agree?
Thank you. Would you like a microphone?
Yes, thank you very much, Jonathan. As we had a couple of words before this session, and we have been digging into this issue of how to reap some economic value out of personalized medicine concept already for last half a year under this feasibility study procured by Estonian government. And I understand that we are pretty much agree with your ideas in a sense that there must be value. And everybody agrees that there's some kind of value nearly, and economic value, but at the same time we can see that this is not so easy. So it's like to a lot of people are looking for the lock holes to the elephant in the room, and everybody sees a little spot and says, well, this is a nice place. But I think the next step, what we and obviously a lot of people in the world are trying to do is to get this lock hole bigger, to be a size of window, to see more comprehensively to this whole system which can be reached in implementing this and how to implement this. And really from Estonian perspective, yes, there has been some interest for Estonian developments, but it has been quite general because, as you said, just having a database and having a potential doesn't give you much if you look from the commercial point of view or from industry point of view. So obviously we have to do a lot of work here to actually reach to some kind of specific conclusions or specific plan or strategy. And yeah, in this we also see we need a lot of expertise outside to support this, and we hope that there is a way to cooperate with the best brains in the world. Thank you.
Am I allowed to? Yeah, sure. I would just say absolutely. I think the key is to think long term. The challenge you often see is that people have a little bit they want to solve, just a tiny bit, and they haven't thought out the whole paradigm of what happens from birth to breast cancer, if you like, or what happens from birth to Alzheimer's. They haven't thought through all of the possible ways of intervening. And they don't have in their mind this, they just have the little bit. So I think that's what you were saying, well, I would strongly support looking really hard at the bigger system and then choosing to experiment, if you like, run an experiment on a bit of it. Because you can't do it all at once. But be very, very practical, very, very clear.
Yeah. Thank you.
Thanks a lot.